graphics, and I can see based on your very nice presentation that you know a lot about how to educate cases. One thing which I should have mentioned before, you received the honor of the Mayo Clinic Arizona Distinguished Clinician Award. So you're many awarded, and I learned a lot, not also from your cases, but also the way you were presenting these cases in this very nice, excellent way. Thank you very much. Now I will give the word to my co-chair to announce the last speaker.
Now our last speaker is Dr. HUSSEIN ATTEIA from Cairo, Egypt. The lecture, Transrectal Ultrasound in Evaluation of Male Infertility.
Before I start, I'd like to thank very much the committee, the Congress, everybody, and in particular Professor Tarek Dayassi, who gave me the opportunity to present this topic. It's a very important topic concerning male infertility. It's a broad field summarized by the inability of the male partner to initiate pregnancy. To do that, must have a good and adequate spermatogenesis, normal ductal sperm transport system, and I will talk about this subject: erection, emission, and ejaculation. I won't talk about the factory that produces sperms, but I will talk about the way, the track from the formation of sperms till ejaculation. Now, ductal sperm transport system comprises the lower or distal urogenital tract. It's the prostate gland, the pairs of seminal vesicles, pairs of vas deferens or ductus deferens, and two ejaculatory ducts. What are the indications of TRUS? You know everything about it. It's assessment of patient with azo or oligospermia with low volume ejaculate. Means if your patient comes with infertility with a low volume ejaculate, less than 1 milliliter, you do the transrectal ultrasound. Identifying congenital and acquired abnormalities of the distal sperm transport system. Evaluate the prostate for enlargement due to BPH, or even in performing biopsy and evaluating the prostate if he has a high PSA for prostate cancer. Now, causes of male infertility, it's classified into two: potentially correctable and non-correctable. Now, potentially correctable is obstruction. If there is obstruction, particularly either proximal in the epididymis or the ductus deferens, or distal in the ejaculatory ducts or the ampullary portions of vas. Non-correctable is the factory. It's the testicle or testicular dysfunction. We cannot do anything about this, but some treatment is now recently approved for improving spermatogenesis. To start with, I hate this. Everybody hates embryology, including myself, but I make it easy for you. It starts always in the 5th week, and it ends in the 11th week. But from 5th to the 8th, that's what happens. The division of the cloaca into urogenital sinus and anorectal canal. The mesonephric duct gradually absorbs to the wall of the urogenital sinus. There's the mesonephric duct. It's absorbed to the wall of the urogenital sinus. And the ureters enter separately. The ureters, it's right there. It enters by the ureteric bud, and then it proliferates and metamorphoses and forms the kidney, the metanephron. The metanephron and the ureters goes up, and everybody knows that the mesonephric duct and the gonads, whether female or male, which is indifferent in the first 7-8 weeks, it goes down, or they descend. Now, development of the reproductive system, you have this picture. It's very easy. It's formed of the paramesonephric duct. If this proliferates and matures, the baby will be a female. If the mesonephric duct proliferates, the development will be towards the male. What affects this in the 7th week of development is the presence of the sex region Y. If this gene is present on the Y chromosome, then the development proceeds along the male path. If the SRY is absent, then development proceeds to the female path. Now, the genital tract arises by paired mesonephric and paramesonephric ducts, right and left. The mesonephric duct gives rise to male genital tract. The paramesonephric duct gives rise to female genital tract. The summary of male urogenital tract derivatives is the ureteric bud. It forms the ureters. The mesonephric duct, the red forms the red testis, the efferent ducts, the epididymis, vas deferens, seminal vesicles, and the bladder trigone, and not all the bladder, just the trigone. The urogenital sinus forms the bladder except the trigone, the prostate, the bulbourethral gland, and the urethra. Now again, the anatomy or diagram of the anatomy, what we see by transrectal ultrasound is the prostate in the sagittal plane, which is this one. There you go. And it's reversed. Usually when we do ultrasound, I do it upside down. Now this is the peripheral zone. The peripheral zone is most posterior, and the anterior fibromuscular stroma is the most anterior. The urethra traverses the prostate. The central zone where the seminal vesicle joins the vas deferens or the ductus deferens to form the confluence, and from the confluence, the ejaculatory. The ejaculatory duct. And the ejaculatory duct moves towards the verumontanum into the urethra. The same thing with the axial plane. The axial plane, this is the anterior fibromuscular stroma, and the peripheral zone where the central zone, I'm sorry if I cannot do this, and the central zone where the two ejaculatory ducts passes and traverses to the verumontanum. Same thing, you have it here in the coronal plane. You cannot see the coronal plane by transrectal ultrasound. You use MRI. The MRI gives you a picture like that. Two seminal vesicles, two ejaculatory ducts, the vas deferens, the ductus deferens, and the peripheral and the anterior zone in the coronal plane. You see only the sagittal and the axial plane. Now again, summary of the anatomy of the cell biology of the distal sperm transport system. You have the seminal vesicles that are derived from the Wolffian duct via testosterone stimulation. The prostate from urogenital sinus via dihydrotestosterone stimulation. The prostatic zones is formed of the anterior fibromuscular stroma. It contributes 30% of the prostate mass, and it does not contain glandular tissue. The peripheral zone, the largest zone, forms 70% of prostate gland, and it contains, of course, glandular tissue. The central zone where the ejaculatory ducts traverses the prostate into the verumontanum contribute 25%. And sometimes it's derived from the Wolffian duct. The periprostatic or the periurethral gland, it's the smallest. It's only 1% of the upper urethra and sphincter. It forms the upper urethra and sphincter. Transitional zone, 5% of prostate glandular tissue where BPH arrive. Now, the average size of the prostate in width is 3.5 centimeter, length is 3.5 to 4 centimeters, height 2.5 to 3. The volume ranges from 10 to 35 milliliters. Now, this is the algorithm we use as radiologists. If the patient comes with semen analysis azoospermia, either you do either with a low volume ejaculate, less than 1 cc, so you do a transrectal ultrasound. If the vas is absent or present. Now, it's more than 1 cc, and there is no sperms in the semen, so you do a transrectal ultrasound, you see the vas absent or a vas present. If the vas is present and the volume is okay, then there is something wrong with the factory, with the testicle. You do a testicular biopsy. Now, low volume ejaculate less than 1 milliliter, what causes it? Stenosis, obstruction, inflammation, congenital abnormalities, absence of unilateral or bilateral agenesis of vas or seminal vesicles. Also, urethral strictures may cause low volume ejaculate. Retrograde ejaculation, whether medical or physiological, may cause low volume ejaculate. Normal volume ejaculate, it means more than 1 milliliters. With azoospermia, oligospermia, the cause is testicular dysfunction, either absent, neglected, cryptorchidism, or even after orchitis. Now, this is the algorithm of male infertility, but I don't think it's very to go through it because it's very sophisticated and difficult, and it concerns the andrologist. I don't think China or India have a problem with that, not even Egypt. We won't go through all this. It's hormonal, and a lot of investigations you do. If the female is less than 35 years and she's trying to conceive more than 1 year, we go through all this. If the female is more than 35 years and she's trying to conceive and failed for 6 months, you go through all this. Now again, the physical characteristics of semen. Not everybody knows what semen contains. Now, the volume of semen is from 2 to 5 milliliters, average is 1.5. The pH is always alkaline. The prostatic secretions is a little bit acidic. sperms contributes only 2 to 5% of the semen volume. The density is 20 million per milliliters. Now, total ejaculate volume from 200 to 300 million. Mean 70 to 80 million per milliliter. Prostatic secretions, 0.5 milliliter. It contributes 30% of semen volume. Seminal vesicles, 1.5 to 2 milliliters. It's 60% of total semen volume. Cooper and bulbourethra gland secretes lubricants or pre-ejaculate lubricants, only 0.1 to 0.2 milliliters. Now, imaging of distal sperm transport system or the seminal tract, we could use plain radiography to see calcifications of the prostates and seminal vesicles. Ascending vasography is only limited to diagnosing vasal patency if the obstruction is at the scrotal part, means proximal, not distal. Now, CT may investigate the whole GUT, and you could see simultaneously the kidneys, absence or presence of the both kidneys with absence or presence of seminal vesicles and vas difference. But the MRI is even more useful. They could see the prostate and seminal vesicles in the coronal plane, and even more detailed integrity of the seminal vesicles and the vas difference using endorectal surface coil. Now, ultrasound, transabdominal and transrectal, I will show the pictures. Now, this is an example of the one on the left, the seminal vesicle calcifications in a person with azoospermia. Again, the CT in the axial plane at the base, you could see both seminal vesicles readily, a little bit towards the apex, towards the symphysis pubis. You see the prostate, heart-shaped. Posterior to is the rectum. The peripheral zone is outside, is here. There's the rectum, that's the peripheral zone, that's the anterior. This is calcifications in it. And then the MRI in the T1 proton density and T2 weighted images show you the integrity and the presence of the both seminal vesicles and the ampullary portions of vas. If you look carefully in the T2, you see the ampullary portions of both vas. This person is normal. Again, the transabdominal ultrasound, if with high resolution, you could see this prostate in the sagittal plane, in the axial plane. Also, if you go a little bit in midline, you'll see both ampullary portions of vas. You could see them here readily without using even transrectal. And here, the ascending vasography, bilateral vasography, you'll see the seminal vesicles, and you see in between, I don't know where's the, okay. You could see in between, there you go. You can see in between the ductus differens and the ejaculatory ducts. Now, those are old transrectal probes I used to use 1992 and 1993 at Boston when I did my PhD there in infertility. And those are sector probes, phased array electronic. This is a linear, this is a sector. This is a bisector and a linear end sector. Now we don't use these probes. The most recent probe, high resolution probe, is with a wide angle end fire. That's, we call it endocavitary probe, which is this one in the bottom. This one, corresponding to that one. And it has an application for guided biopsy. This will go from 120 degrees to 160 degrees angle field of view. Now, that's an example of the normal TRUS examination. In the axial plane, you can see colored, In the axial plane, you could see color Doppler you could use in cases of suspected prostatitis. You could use even on the left here, you could see elastography in cases of seminal vesiculitis, end stage with chronicity and fibrosis of the seminal vesicles. Use elastography, more than one strain ratio will go towards the fibrosis, and the problem is seminal vesicle dysfunction. If you go a little bit to the middle, as you could see readily by transrectal, you will see the calibers of the ampullary portions of vas. Is about 5.1 millimeters. Again, in the base, you could see both ampullary portions of vas, both seminal vesicles. You go by towards the lateral sides, right and left. Right and left, you could see the right seminal vesicle, and down here, the left. Again, the prostate in the axial plane, you could see the bladder neck going towards traversing the prostate, and the sagittal plane. This is the urethra, the bladder neck, and the urethra, Cooper gland, and you could see here a little bit carefully. You could see ejaculatory duct traversing the central zone towards the verumontanum. Now, this is a real video image in the axial plane. You could see here both the prostate And if you look carefully, you see both ampullary portions of vase at the base and the seminal vesicle. You see also prominence of the periprostatic vascular channels in a patient with varicocele. And this is in the sagittal plane. You go left to right, from down to up, and you could see both seminal vesicle and measure them. And you could see calcifications here in the prostate. Now, prostatic lesions are prostatitis, prostatic abscess, calcification, cyst, midline or paramedian cysts, BPH, and tumors, either primary or secondary. Now, let's start with acute prostatitis. You could see a swollen prostate. This is an old image using ATL. And you could see patches, loss of zonal texture, echogenicity, edema by the hypoechogenicities between the central gland, transitional zones, and the peripheral zone, with loss the echo pattern of the peripheral zone. Again, another prostate in axial plane, you see an abscess surrounded by edema, calcifications, even obstruction of the right ejaculatory duct. If you go parasagittal in the sagittal plane, you could see dense fibrosis and calcifications of the prostate in patient with ejaculatory duct obstruction. There as you go, there's this on left side, there's dense calcifications and fibrosis and unilateral ejaculatory duct obstruction in the axial plane, and the same patient in the sagittal plane. Now, prostatic cyst non-communicating. What do you mean by communicating? It means communicating with the urethra, and the cyst contains sperms. So what are those? Those are non-communicating, means those cysts in the prostate causing compression of the ejaculatory ducts, and they do not contain sperms. One of them is the utricular cyst. It's a congenital anomaly of the utricle. It's a slit-like over the verumontanum, and it doesn't contain and extends beyond the prostatic boundary. And this is in midline in the axial plane. You could see it here again in the sagittal plane. The vasography will see dilatation of both ejaculatory ducts and splaying of the ejaculatory ducts by the midline cyst. Now, the example of communicating, which is the presence of a Wolffian duct cyst. The Wolffian duct is a congenital anomaly, sometimes associated with other anomalies of the urogenital tract, like agenesis or dysplasia of the ipsilateral kidney, and sometimes contralateral ampullary portion of vase, agenesis, and seminal vesicle hypoplasia. This is an example of the cyst near the seminal vesicle. This is a Wolffian duct cyst, and it contains sperms. You could see the vasography, the ampullary portions of vase and seminal vesicles emptying into the midline cyst. And this patient has an oligospermia. Now, another communicating one is ejaculatory duct cyst. There you see it, paramedian, right? If you go sagittal down there, you could see a stone and stricture, and this is the ejaculatory duct dilated, communicating with the seminal vesicle and ampullary portion of vase. The same patient has a seminal vesicle marked dilatation of the ampullary portion of vase and the ejaculatory duct. Now, example of seminal vesicles. The congenital anomalies, either unilateral or bilateral. This is a unilateral. You could see one of the ejaculatory ducts present. You could see here bilaterals that are absent, and there are bilateral absence even with vas difference. You could see here nothing. At the base, there is no seminal vesicles and no ampullary portions of vas. Or hypoplasia. Hypoplasia, you could see a very small, thin-like left hypoplastic seminal vesicle, and you see here bilateral hypoplastic seminal vesicle, and even a thread-like small seminal vesicle. We call it agenesis, even if you have this. You could see here also congenital cyst. If you have a congenital cyst in one seminal vesicle, it means he has other congenital anomalies elsewhere. And you could see here that the contralateral side on the right side, on the right side it's present, the vas difference is present, and even communicating before the ejaculatory ducts to the seminal vesicle cyst. The contralateral side is absent. This one is a seminal vesicle communicating with the urinary bladder. Now, seminal vesicle acquired abnormalities include obstruction and cystic dilatation of the seminal vesicle and ampullary portion of vas, either unilateral or bilateral. This one is by stone, this one is by stricture. And you could see a unilateral obstruction using vasography, dilatation of the seminal vesicle, and vas difference. Now, calcifications due to severe infection. You could see both ampullary portion of vas at the base and both seminal vesicle containing concretions. This happens with tuberculosis. Or hemorrhage. You see marked dilatation and enlargement, a fleshy consistency of the seminal vesicles, and you can find septa here, and this is filled with hemorrhage and sometimes pus. bilateral obstruction of the confluences. You could see it on the far right. You could see bilateral, this is left and right, confluence obstruction with marked dilatation of the seminal vesicle. When do we see dilatation? If the width of the seminal vesicle exceeds 15 millimeters, we call this cystic dilatation. Now an example of acute seminal vesiculitis and prostatitis. You could see here an infection by Staph aureus, and the Staph aureus, that's marked dilatation of the seminal vesicles with debris and pus. Even both ampullary portions are markedly dilated and enlarged. Usually the ampullary portion of vas does not exceed 6 millimeter in caliber. You could see here they are 8 millimeters and even more. Color Doppler we could use, and you see the marked hyperemia at the peripheral zone. Even the seminal vesicle, you could see hyperemia of the seminal vesicles and of the prostate gland. Now, example of chronic seminal vesiculitis is calcifications. This is with B. coli, calcification of the seminal vesicle, and calcification of both ampullary portion of vas. I don't know, where did I go? There you go. And this is calcification of the ductus deferens. You see all the calcifications, this by TB. And this is vas deferens, bilateral calcifications, and this dense calcifications and occlusion of both ejaculatory ducts. Now, vasal abnormalities. Vasal aplasia accounts for 1 to 7 in 1,000 individuals. Bilateral aplasia accounts for 1 to 2.5 in fertile men. And renal anomalies were found in 26 to 43% of patients with agenesis of vas. Seminal vesicle abnormalities associated with vasal aplasia are reported in 92 to 100%. And usually, if you have seminal vesicle abnormalities and vasal aplasia, you have ejaculatory duct aplasia as well. Now, congenital unilateral absence of the scrotal vas is rare, accounts for only 0.01 to 1% of healthy individual. Most of them, 70%, occurs in the distal portion. And the incidence of ipsilateral renal agenesis of part of the vas is usually common with seminal vesicle cyst, as I showed you. Unilateral agenesis of vas associated with contralateral mesonephric duct abnormalities are very common. Now that's an example, as I told you, of the seminal vesicle cyst and the ampullary portion communicating with the seminal vesicle. Here you see the ampullary portion directly communicate with the seminal vesicle with obstruction of the ejaculatory duct. The contralateral side is absent. Another example, and this the same example as that one. That's a congenital anomaly with ipsilateral absence of the kidney. Now vasal agenesis bilateral is a single case. You have ejaculatory duct cyst congenital, and you see it communicating with the ejaculatory duct with the urethra. And this is the cyst in the seminal vesicle. You could see it here, and the patient has agenesis of the right kidney. Another case with ejaculatory duct cyst. This is a primary ejaculatory duct dilatation, and it's like Wolffian duct, a cyst communicating with the urethra and with absence of the vas deferens and hypoplastic seminal vesicles. Now, acquired ejaculatory duct dilatation, either bilateral or unilateral. Either bilateral or unilateral. You could see it here bilateral. You could see seminal vesicle marked dilatation on both sides, and both ejaculatory ducts are dilated at the base of the prostate. This is by stone, and here by stricture. Now, correction of vasal ejaculatory duct obstruction, I'm almost done. It's proximal obstruction. We do vasoepididymostomy or transeptal vasoepididymostomy. Distal obstruction, which is very correctable, is distal obstruction by transurethral resection using a resectoscope or loop resection of the ejaculatory ducts for careful unroofing of the duct in the vero itself. Now, vasography is only reserved, as I told you, for preoperative assessment to verify level of obstruction. Transrectal ultrasound-guided aspiration to see if this cyst contains sperms or not. This is a Wolffian duct cyst, and you could see the spinal needle traversing and going through the cyst. Finally, summary and conclusion. It's non-invasive, availability, office-based modality, reliable mean for the evaluation of the distal sperm transport system. It's low cost and provides new diagnostic criteria in the presence of color Doppler and elastography. A variety of rare congenital anomalies could be seen by transrectal ultrasound. Thank you very much. Always remember that to tango, you must have both male and female checked up. And the lovely thing, which is in this case, is the background. If you could see the background, it's in the PowerPoint. We did not tailor it, and you could see here sperms all over, swarming around. My son found that, and he chose this for me to put the infertility pictures on it. Thank you again.
Thank you very much for this excellent overview. With this, I would like to close the session. It's time for lunch. If you have questions to the speakers, you can address them personally, not in front of the audience. So thank you very much, and perhaps see you at the next meeting.